Amputation, forearm, through radius, and ulna. The physician cuts the soft tissue flaps distal to the intended level of bone amputation. The physician dissects the superficial veins and cuts them at the level of the amputation. Cutaneous nerves are cut proximal to the level of the amputation. The dorsal and volar antebrachial fascia is cut, and, depending on the level of amputation, the tendons or muscle bellies are divided after the radial and ulnar vessels are severed. Muscle bellies are incised just distal to the planned level of bony resection. Nerves are cut through a separate incision, and brought under the muscle. The anterior and posterior interosseous vessels should be ligated or coagulated with electrocautery. An incision in the periosteum is carried out sharply and circumferentially. The bone is transected at the desired level at this time and the specimen is removed. The bone ends are smoothed with a rasp. Closure is accomplished after hemostasis is obtained following tourniquet release. The skin flaps can be fashioned, and subcutaneous tissue and skin are closed in separate layers. A drain is sometimes placed. The stump is dressed and wrapped with an elastic bandage applied more firmly distally than proximally. Amputation, forearm, through radius, and ulna, re-amputation. The physician performs a re-amputation. A re-amputation may be necessary at a proximal level to reach healthy tissue. Amputation, forearm, through radius, and ulna, open, circular, guillotine. The physician incises the skin in a circular manner down to the deep fascia and allows it to retract. The muscles at the edge of the retracted skin are divided. All vessels encountered are ligated and divided. All major nerves are divided at a proximal level so that they retract proximal to the end of the stump. The physician sections the bone at the ends of the retracted muscles. The bone end is covered by the distal muscle bulk, and the skin is stretched over the stump and sutured closed. Amputation, forearm, through radius, and ulna, secondary closure or scar revision. The physician performs secondary closure or scar revision after the stump has granulated or healed by a scar. In this procedure, no additional bone is sectioned. The physician resects the scar and granulation tissue from the end of the stump. Skin flaps are fashioned as close as possible to the thick scar surrounding the granulating wound. The dense layer of scar tissue is excised from over the end of the bone. Additional muscle may be removed as well. Cruckenberg Procedure. The physician performs the Cruckenberg Procedure, a forearm amputation. The physician longitudinally splits the stump into radial and ulnar rays by making a dorsal, longitudinal incision toward the ulnar aspect of the forearm. Also, a volar, longitudinal incision is made toward the radial aspect of the forearm. The muscles left or transferred to the radial side of the forearm are the radial wrist extensors and flexors, the flexors of the index and long fingers, the index and long finger extensors, the pronator turcs, the palmaris longus, and the brachioradialis. The remaining muscles are left or inserted on the ulnar side of the forearm. On occasion, some muscles need resection to reduce bulk, but the pronator turcs must be preserved. The interosseous membrane is freed along its ulnar border. Skin closure is performed, ensuring the tactile skin is placed over the contact surfaces between the radius and ulna.